Hello and welcome everyone. Today's presentation is on the Canadian Cardiovascular Society's update on post-cardiac arrest care and refractory cardiac arrest patient care. Out-of-hospital cardiac arrest is quite common. Up to 40 to 111 patients every 1 lakh person is the annual incidence. The survival rates are very poor and the quality of care and public health needs to improve before we can actually get better outcomes. The previous statement was in 2017, which mainly focused on in-hospital arrest based on some observational studies and RCTs. However, there have been large RCTs and even including out-of-hospital cardiac arrest patients recently, and thus these studies are going to influence the current position statement. So the first thing is the role of coronary angio. In this, we already know what are the benefits of doing a coronary angio. So the timing is to be done early if in the initial ECG you are finding STEMI findings. So the benefits are mostly hemodynamic to prevent hemodynamic decompensation, mechanical cardiac complications, arrhythmias. So in 2017, the guideline was to use angio PCI fibrinolysis if the patient is having STEMI. The problem here is the neuroprognostication. Reliable neuroprognostication is not available because the patient is just resuscitated and is in coma. So at this moment, we don't have any method by which we can neuroprognosticate and tell with certainty a bad neurological outcome, and in those patients not do a STEMI. So as of now, neurological injury is a significant competing risk factor, but the evidence doesn't support to withhold the angio in these patients, or because we don't know who these patients are actually. So patient with STEMI, go for a PCI. So what to do with the patient is not on STEMI? Well, we already know what are the benefits of STEMI. We will look at the recent trials that have been done. That is the COACT trial, 552 patients with non-ST elevation, immediate versus delayed group, no significant difference in the outcomes. The next is Tomahawk. It had similar patient eligibility criteria. This time the immediate versus delayed, 3 hours to 147 hours, and again no significant difference. Meta-analysis of 6 hours CT doesn't show any difference. So as of now, for all practical purposes, because there has been a lack of benefit, and we have seen that there is a varied group of patients who may be a part of this group, that is non-STEMI group. So, and already we have a competing risk factor, that is severe neurological dysfunction. Until and unless there are certain risk factors, you don't go for a angio. So what are those risk factors? These are the hemodynamic instability, high risk ischemic ECG changes, recurrent ventricular arrhythmias. Only then you go. So to summarize this overall, if the patient is having ROSC after out-of-hospital cardiac arrest and you suspect a cardiac cause, if you find ST elevation, go for an angio. No ST elevation, look for the risk factors, that is hemodynamic instability, high risk ECG, and recurrent and unstable ventricular arrhythmias. If they are present, then you can consider to go for an angio. If no, then you can wait. There is no need to hurry up with the angio. You can go with a neuroprognostication, and once it is done properly, you may then go for an angio. Now, the post care that needs to be given, that is the temperature control. The definition is that we should control the temperature actively after a cardiac arrest, and mostly studies in the past have shown that lowering the body temperature has a positive outcome. Thus, in 2017, the guideline was to maintain TTM for all unresponsive post-ROSC patients. The target was 33 to 36 and for at least 24 hours. But there have been a lot of trials recently which have looked into the various aspects of temperature control, and we will discuss them right now. That is the studies, that is TTM2 trial, 33 versus 36, no difference in outcome. TTH4, they did this hypothermia for a longer period, 48 hours, but then no difference again, and in patient who had intravascular cooling, there was bleeding risk associated. RINS trial, a pre-hospital trial, no survival benefit. ICE-PAC pre-hospital, no survival benefit. Princess pre-hospital, again no survival benefit. And TTM2, a large trial, 33 versus 37.5, no difference in 6-month outcomes. mild hypothermia was associated with more hemodynamically significant arrhythmias. And next is the capital chill, mild versus moderate, and no significant difference in outcome. Hyperion, hypo versus normo, no significant difference. And Haka in hospital examined mild versus normothermia and no difference in outcomes. So the expert opinion is that for all type of shock or shockable or non-shockable rhythm in hospital or out of hospital arrest, maintain a core temperature of less than 37.5. So giving a more detailed summary for temperature management, you initiate a temperature control once the patient is in the hospital. Don't try to do it in the pre-hospital setup. All the studies have shown worse outcomes and complications while trying to do this. And for temperature, target it to keep it less than 37.5 as per your institutional protocols. Monitoring, always do a core temperature monitoring. And the duration has to be 72 hours. It doesn't mean that you do hypothermia. Hypothermia is not to be done. This temperature control, that is to maintain a temperature less than 37.5, needs to be done for at least 72 hours. Blood pressure target. Blood pressure is important because it needs to deliver the oxygen to the already damaged brain. And the current understanding is to keep a map of around 65, and most of this is coming from critical care literature, not really in patients who had cardiac arrest. And the recent RCTs that have been done, that is box trial, 789 patients, 77 versus 63, no significant difference, and no difference in complications either. Neuroprotect, a higher map target but no difference. Coma care, again a higher map target but no difference. And the use of higher map obviously resulting in more vasoactive drug usages. So the optimal map is not particularly known because the autoregulation is affected, and the studies have their individual problems also. So the expert opinion is to keep a map of more than 65 and achieve a goal that is considered to be okay for all patients who have been resuscitated from coma. Now we do know that higher map can probably be able to save some kind of a neuronal tissue, but we are not very sure of that as of now, and it does result in very high usage of vasoactive drugs which have their own side effects. So the summary is same, keep a map of more than 65. Optimal oxygen targets, the 2017 guideline says 60 millimeters of mercury to 200 millimeters of mercury. These are mainly based on observational studies. We have some recent RCTs. The box trial, 68 to 75 versus 98 to 105, and there was no difference in terms of the outcomes, and similar incidence of adverse effects as well. Exact trial, similar findings, but it was underpowered because of the COVID-19, and this had a slightly higher target, that is 90 to 100% of saturations. And TTM2, there was a secondary analysis. In this, they did a very interesting finding, that was they found a U-shaped relationship with the PaO2. So in the extremes, they had high mortality risk, and they have a middle period where the risk was not so very high. And the hyperoxemia time, if the patient was there, it also had a worse in terms of 6-month mortality. So avoid both extremes and try to keep in the in between. So the expert opinion is to keep it between 68 to 105 and avoid the extremes. Next is the partial pressure of carbon dioxide. In this, the logic is that if you maintain a hypercapnia, you can increase the blood flow into the brain and probably save some of the brain tissue. Now, the hypocapnia obviously will result in vasoconstriction and may probably have worse outcomes. So recently there has been a trial, that is a TAME trial. They used 1700 patients who had a ROAC more than 20 minutes with 4 score of less than 4, and they kept a PCO2 of 50 to 55 versus 35 to 45, and they did not find much of a difference in terms of the neurological outcome or mortality. Adverse effects were similar, but the requirement of sedation was slightly more in the hypercapnia group. Now, target normocapnia in the patient. As of now, there is no such benefit of giving hypercapnia. Role of prophylactic antibiotics. There is a very high incidence of aspiration pneumonia in these cases. There have been some RCTs The pilot study did not find any difference in the prophylactic antibiotic, but Anthractic trial found a lower incidence of VAP. But as of now, for the experts comment that we should not be giving antibiotics for pneumonia for prophylactic purposes. Regarding seizure and high risk EEGs, the presence of seizures is a very poor prognostic marker and is associated with unfavorable outcomes. However, if you don't find seizures but find EEG changes like generalized periodic discharge, then probably we need to think about it. So there has been a trial, that is the Telstar trial. In this, they had 742 comatose patients and they looked to treat the EEGs. And in this, they found that controlling the EEG did not result in much of a difference in the neurological outcome. So the expert opinion is, if the patient is having seizures, then you can control it. But if for EEG changes, there is no need to go for seizure prophylaxis or treatment. This is the summary of the treatment that needs to be given. Initially, you decide whether angio, whether if it is STEMI, go for angio. If you have risk factors, go for angio. Then you give the supportive treatment, MAP, PO2, PCO2 targets, and you have some interventions like seizures, temperature, and antibiotics. Regarding the management of refractory cardiac arrest, so in this we try to find the antiarrhythmic drug that need to be given in shockable rhythm. So mostly people prefer amiodarone, but there has been a study recently which was the ALPS trial. They compared the similar patient group. They compared amiodarone, lidocaine versus placebo. In this, they found no significant difference in terms of outcome. But in a subgroup, that is in witnessed cardiac arrests, amiodarone and lidocaine has a much better control over the refractory VF and VT compared to placebo. And the expert opinion is that if the patient is having a witnessed cardiac arrest and a refractory VT or VF, in that case, you go for amiodarone and lidocaine. Defibrillation strategies, the importance is that we need high quality compressions, and the definition for refractory VF or VT is that there must be an absence of ROAC after 3 shocks at 2 minutes interval. If you have given already 3 shocks and then still you are having VF or VT, then you can consider this particular condition to be a refractory VF. So for this you need alternative defibrillation strategies. So there are alternative pad positions which have been found to be of no significant difference. Defibrillation techniques are there which can be of benefit. So there is something called double sequencing defibrillation and change of vector. So the study was dose VF. It was 405 pre-hospital patients, and in this patients who had a refractory VF and VT, they gave sequential double sequence defibrillation, vector change defibrillation, and standard defibrillation, and they found better ROIC with double sequence, and vector was less but still better than standard care. So survival was definitely better with both the groups. So the expert opinion is, if you are having a refractory VF or VT, then please go for these alternative strategies, that is double sequence and vector change, provided you have trained staff and equipment available. Regarding eCPR, the logic is to maintain and keep the systemic perfusion while taking your time and getting the heart back with targeted interventions. But it is resource intensive and high costs. So there have been studies, the ARREST trial, 30 patients. Actually, this was a very small study, but it did found very significant survival benefit. But it could not be replicated in the future trials, 256 out of hospital patients. And in this, they could not find any significant difference in the mortality. Inception, again 160 patients, and again no significant difference in the mortality. So the expert opinion is the eCPR is to be done in a select group of patients with low comorbidities in an experience center. So if you have all the things going in, then you may go for a eCPR. And the time to cannulation from arrest has to be less than 60 minutes, and from patient inside the hospital it has to be less than 30 minutes. Now, cardiac arrest regionalized system. So this is the whole idea regarding making hospitals which specialize in cardiac arrest care. Now, there have been some findings in the observational studies which show that high volume centers have lower mortality rates. So there have been some studies based on this. There is an Arizona statewide study which found that EMG triaging and sending it to a cardiac arrest center improved outcomes and survival. And arrest trial, it was done in London. Actually, in this trial, they could expedite it to a specialized center or to other hospital. Though they found increased intervention in the specialized center, but in terms of outcome, they could not find much of a difference. Now, the subgroup analysis showed that if the patient was less than 57, then probably the improvement rates were higher in the specialized center. Now, the limitation of the trial is this is done in a very urban setup in a very advanced country with all facilities. So probably most of the hospital will be having very advanced care, even though they are not specializing in cardiac arrest care. However, in rural areas, probably this type of model of having a cardiac arrest center could be of more benefit. So this can be replicated in rural areas rather than in urban areas. So that is the recommendation of the group, and thank you for your patience.